I'm starting again. So basically, today I'm going to talk about the obstructive lung diseases. Yesterday, I told you that what are the obstructive lung diseases and what is the basic difference between obstructive and restrictive lung diseases. Today, I'm going to talk about the obstructive pulmonary diseases, what it includes, and what are the manifestations, and then we will be talking about the rehabilitation part in these conditions. So, broadly speaking, obstructive pulmonary diseases includes chronic obstructive pulmonary disease, that is COPD, which includes bronchitis and emphysema, and the other obstructive conditions which we are going to study is the asthma, bronchiectasis, and cystic fibrosis. Now, starting with the COPD, it is said to be a preventable and treatable disease. Why it is being said to be a preventable disease? Because there are certain risk factors which are responsible for COPD. So if those factors are controlled, then there are chances that it can be prevented. And once it is developed in someone, then it is a treatable disease. The cure is available. Not only it has the pulmonary manifestations, the pulmonary effects, but there are certain other extra pulmonary effects that may also contribute to the severity in the individuals. So this means कि COPD का जो patient है उसमें सिर्फ आपको respiratory symptoms नहीं मिलेंगे, you will be able to see certain other extra pulmonary effects as well. Now जो COPD है that is being characterized by airflow limitation, which is not fully reversible. Not fully reversible का मतलब कि even if you will treat that case, तो जो airflow limitation patient में develop हो गई है वो वापस से completely recover नहीं करेगी. It can be treated, but it is not fully reversible. And this airflow limitation, जो obstruction है, जो airflow limitation patient को है, that is both. It is progressive, means it will gradually increase, and it is associated with abnormal inflammatory responses. तो जो भी noxious stimuli जब patient expose होता है उन stimulus को, तो these changes they keep on increasing. These inflammatory responses they increase. Now, as I said that it is preventable. So if you know the risk factors, then to a certain degree you can prevent this disease or you can deal it. Now, there are two kind of factors. They are the host factors. Host factors means the factors which are within the person in whom the disease is happening, like the hyperactivity of the airways, then the overall lung growth. Then, as I said, that it is composed of two components, the bronchitis and emphysema. So, genetics play an important role, especially in case of emphysema, where there is a deficiency of alpha-1 antitrypsin. So, it is inflammatory mediated gene, which the deficiency of which may lead to further development of the disease. And there are the other factors, which include the environmental factors. Now, environmental factors means the factors from the surrounding. So, like tobacco smoke, one of the major reasons for the development of COPD is the smoking. The active smoking, the person who smokes is the active smoker, and the people nearby who are getting exposed to that smoke are the passive smokers. So, the people in the surroundings where smoking is happening, so suppose in a family there are four people and one male member of the फैमिली वो स्मोक करते हैं घर में, तो जो घर के बाकी तीन मेंबर्स हैं अगर वो उनकी विसिनिटी में है तो दे विल आल्सो बी द passive smokers because they are getting the smoke though they are not actively smoking it. So tobacco smoke is one of the factors which is responsible for this condition. Then the other dust and chemicals, indoor air pollutants, outdoor air pollutants, and as I said, in the rural areas, when the use of these chulhas and all wood, burning of the wood and coal, that also leads to smoke production, and that can also to some extent lead to the obstructive condition. So when we talk of the pathophysiology, physiology means what is normal in the body, and pathology means what abnormal changes are there. So when I talk about the pathophysiology, so before going on to the pathophysiology, if we talk about the definition of emphysema and chronic bronchitis, how you will define them. Emphysema is the destruction of the gas exchange surface of the alveoli. So the where the gas is is taking place in the alveoli, the destruction of that region is termed as clinically as emphysema. Whereas chronic bronchitis is clinically defined as the presence of cough and sputum production for at least 3 months, and this should be happening for consecutive 2 years. It remains one of the most clinical and epidemiological defined terms. So first, let's start with the chronic bronchitis. Chronic bronchitis means bronchitis is the inflammation of those bronchioles. Now, chronic, it is being said that, as the definition says, that it should be for at least 3 months and for consecutive 2 years. So that period is a long time. So whenever there is, if you can see this flow chart, so whenever there is a repeated inhalation of the tobacco smoke or the irritants which are irritating the alveoli, if those environmental exposures are being repetitively exposed to the patient, there is irritation of the airway lining and the mucosal damage starts happening. Now, because of this mucosal damage, what will happen? First thing that will happen is the inflammation. Second thing will be, because mucosa is being it is being getting irritated, so there will be hypersecretion of the mucus. And the third thing that will happen will be the soft whatever the soft muscles over there we have, the those will go into bronchospasm. So these three main features will start happening. Now, when bronchospasm will start happening, it will lead to stimulation of the parasympathetic nervous system. And due to parasympathetic nervous system, there is release of acetylcholine, and this will lead to breathlessness in these patients. Inflammatory changes will lead to, because of inflammation, there will be inflammation of the this bronchioles and airways. There is excessive mucus production, so the airways will have little obstruction because of the mucus. Then what we can say is the patency is being reduced. जो अंदर का उसका area है, that is being reduced, so obstruction will start developing. And because of inflammation as well, narrowing होगी distal airways की. So this will lead to chronic inflammation, and this chronic inflammation will lead to fibrotic changes and scarring, and this all will ultimately lead to breathlessness. So breathlessness होने के जो exact factors हैं, that is how that inflammation is developing. So that if anybody talks to you and says that it is chronic bronchitis, it is not just the inflammation that is responsible for the breathlessness. The mucus hypersecretion, the bronchospasm happening, stimulation of the parasympathetic nervous system, release of acetylcholine, all these together, they come up with the excessive breathlessness in the patients with COPD, especially this bronchitis. Now, if you see the emphysema, what is happening in emphysema? So when this primary emphysema, it starts happening, that mainly happens because of lack of the alpha-1 antitrypsin. So this will lead to the protein breakdown. Because of the protein breakdown, there will be erosion of the alveolar septa, dilatation of the distal air spaces, and whatever the elastic fibers are there, they will all get destructed, and this will lead to the floppy airway collapse. So this is one of the mechanism, and this protein breakdown will also be leading to the alveolar damage and smoking, which is happening because of the smoking, which leads to the secondary emphysema. So it can be primary one as well, in which there is lack of the alpha-1 antitrypsin, or because of the secondary smoking and all, there is protein lockdown, and which can lead to further secondary emphysema. Now, so whether it is emphysema or bronchitis, in both the conditions, the ultimately the exchange of gases are hampered, and what we say is the arterial content of oxygen in the partial pressure of oxygen in arterial blood, and the partial pressure of carbon dioxide in arterial blood, they all get started hampering, So elimination of those CO2 becomes difficult, and there's reduction in the oxygen delivery. So how this happens is when chronic bronchitis happens, there's airway damage, which will lead to patchy damage and extensive damage. So there will be extensive damage if any structure is damaged or there is hypersecretion of mucus. So the ventilation and perfusion mismatch starts happening. There is not adequate amount of air with the amount of blood, and ventilation perfusion mismatch happens. When this happens, there is hypoxemia, that is the decrease in oxygen content of arterial blood. This is not happening till the tissue level, it is the further stage further. So hypoxemia will happen, and because of hypoxemia there will be polycythemia. So excessive production of those RBCs will start happening because of the lack of oxygen in arterial blood, and this hypoxemia will further lead to oxygen delivery to the tissues is decreased. So hypoxemia will lead to hypoxia. And if we see about the emphysema, in emphysema there is alveolar damage, which will lead to scarring, and then again it will follow the same sequence. There will be V by Q mismatch, that is ventilation perfusion mismatch will be there, and this will lead to hypoxemia and decreased oxygen delivery. Also, when there is bronchitis, because of that fibrotic regions and excessive inflammatory changes, there is hypoxic vasoconstriction. So the extensive damage will also lead to effect on the pulmonary vessels, and there is development of pulmonary hypertension, and this leads to cor pulmonale. So basically, cor pulmonale is the failure of the heart because of the development of lung pathology. So because pulmonary hypertension has happened, so this will affect more the right side of the heart. So initially there will be right heart failure, and then in future stages there can be left heart failure as well. So this is how the disease progresses. So it ultimately, if it is a chronic obstructive pulmonary disease, it doesn't mean that in later stages it cannot affect the heart. So heart may get affected in future if no proper management is being taken. This is how the progression of COPD takes place. Now you see these are the patterns how you will see the patients. So you can see these patients of bronchitis and emphysema, the presentation. There are two kinds of patients. One is the blue blotters, in which the symptoms will be the patient will mostly be obese patient. So this means that if we talk about the WHO guidelines of obesity definition by BMI, then it says that anybody with a BMI greater than 29.9 kgs per meter square is the person who is defined as obese. So if you find the person blue blotters, then these patients may have mild dyspnea, they will have a lot of sputum, oxygen content is decreased, and that is one of the reasons why they appear blue. Bluish is the cyanosis. You will see the cyanosis changes in this. So central cyanosis will be there, so the lips will be bluish in coloration, the tongue will be bluish in coloration. So oxygen content is definitely reduced, and there is high PaCO2. Peripheral edema, because the central cyanosis is there, this may lead to cor pulmonale. So peripheral edema, heart is being affected, so peripheral edema is a sign which you can see. uh, Increased, and because PaCO2 is increased, so there is retention of the air in the body. So residual volume will increase, but the total lung capacity will remain normal. The other patients who are defined as the pink puffers, they basically have these symptoms that they are generally, if you look at the body, they are thin with anxious expressions, they have a lot of breathlessness, sputum, not necessarily, they have relatively normal PaO2 and PaCO2. Central cyanosis may be present, not necessarily they will have. They may have central cyanosis, and but the chances of development of cor pulmonale are less. Peripheral edema is not seen, and in these patients, the total lung capacity is increased, and that happens due to hyperventilation. These patients hyperventilate. So, when we talk of the clinical presentation of the patients with COPD, the symptoms, the sign and symptoms basically which the patient brings up is that they have a lot of cough, they have sputum production, Then they will have a lot of breathlessness and shortness of breath will be there, especially with the exertion. So at rest, they may not, in initial stages, they may not report any breathlessness. But when the patient is exerted, especially with any kind of physical activity or any kind of ADLs they are performing, which needs some ADLs or IADLs or any kind of work they are performing, whenever they are getting exerted, they can be shortness of breath, wheezing can be there, and especially I have made you people hear how wheeze is there. So especially you will see the wheezes, especially when the patient exhales out. So in expiratory phase, the patient may report you symptoms of chest tightness, and the patients who require hospitalization, actually they have a lot of symptoms. So the earlier symptoms which I told you, these patients generally come up to the outpatient rehab departments. But the patients who require hospitalization, they have a lot of breathlessness. So if you will take the breathlessness, there will be a moderate or severe level of breathlessness. Then they will be the breathlessness can be as such that they may have difficulty talking. Lips and fingernails, you can see cyanosis. So cyanosis, that is why I've written that lips or fingernails may turn blue or gray. They may, because of so much decrease in the oxygen content and increase in the CO2 levels, they may not be mentally alert, and they may have the increase in this heart rate as well. So increased heartbeat is seen. So sometimes they may report palpitations as well. So, whenever we see these patients of obstructive conditions, especially the bronchitis and emphysema, that is when I talk about the COPD, the assessment part, we have dealt the assessment in detail when we were doing the cardiopulmonary assessment. So, here I'm quickly going to talk about the assessment, what should be done, particularly in these cases. Fine. So demographic data, as we take in all the patients, you need to record the demographic data of the patient for the identification, where the patient resides, what is the age and gender identification, and also you need to take the demographic data. Then you need to ask the chief complaint. So here, when we talk of the respiratory pathology, and particularly we are talking about the COPD, so patient will complain you mostly ki we have breathlessness from this and time. The patient may report you that I have such short of breath that I'm not able to talk, I'm not able to walk for certain small distance of time. I have difficulty wearing my clothes, or these kind of basically chief complaints the patient will come up with increased respiratory rate. And if cyanosis and all is present, then the patient, you can see, and patient sometimes may report you as well in chief complaint also that this is what I'm finding. So, but primarily what patient will be reporting as chief complaint will be mostly the problem with the catching of breath, that we are not able to take breath properly and it is very, very dyspneic. Then you start taking the history. So you need to start history as we take in cardiorespiratory assessment. Here also we need to go in that format as well. So you need to talk about the present history. Now present history means the history pertaining to the condition for which the patient has come to you. Then secondly, you will go up to the medical history. So medical history, you will take off that what all medications the patient is having, he's having any associated conditions or not. Apart from this present and medical history, you need to talk about the past history as well. Okay, that if the patient has these symptoms earlier as well or not. Then you need to talk about the family history. If anybody in the family have certain kind of disease or not, any initial complications were in the family, or when we talk of the hypertension and diabetes mellitus, then are such kind of conditions already present in the family, or the patient has come up with whatever condition, is this kind of condition present in the family. So you need to talk about the parental and maternal and parental, both the sides. Then personal and social history. Now this becomes very important here in COPD. Personal history, you should know that whether what risk factor the patient has been exposed to. This will help you in making the diagnosis easier. So what all personal history, whether there's any history of smoking or not, if the patient has been smoking, how long since he has been smoking, what are the pack years, what kind of smoking he's being up to, whether it's a or anybody in the family is smoking and he or she is just a passive smoker. So you need to take off all that kind of history. Then social history, that how much the patient is active in the society, the patient is undergoing any other isolations or not. So you need to ask the social participation as well. Then comes the a detailed assessment where you need to observation. Now in these patients, I have specifically mentioned what all you will be able to see in observation. So if you look at the posture, you can see kyphosis in these patients. The barrel shape with over the period of time, the chest becomes barrel shaped. Thoracic excursion is decreased, so that is visible. Use of accessory muscles is lot of there. I told you yesterday that how this use of accessory muscles is happening. So again, I'm just for a minute, I'm just coming back and sharing the blackboard so that I can explain you once again that why this use of accessory muscles and work of breathing is happening. So yesterday I told you that there is hyperinflation. The patient is not able to eliminate out the CO2. There is retention. And in these patients, they start catching the breath. This is what all we yesterday talked about. So I told you that the diaphragm is dome shaped at rest. During inspiration, it has to go down. So it becomes horizontal. It has to go down during inspiration. It has to go down. Okay. Now, these patients, they are not able to eliminate out the air properly. They are not able to take the air properly. So this diaphragm, this excursion is getting affected and it doesn't get relaxed completely. So when it has to relax, it should go properly into dome shape. That doesn't happens, and so it remains in partial state. So it is a more of a kind of a flattened diaphragm, neither in complete inspiration nor a complete exhalation. For any muscle to work, complete relaxation of that muscle is important for complete contraction. So lengthening is important actually. So here in these patients, this is not happening, and since it doesn't happen, so what happens is that the accessory muscles, the patient starts becoming dyspneic, and the accessory muscles, they become active partners in this. So you see a lot of active use of those muscles. Fine. So this is how the use of accessory muscles. So when you will look at the neck region, you can see the cyanosis. Use of accessory muscles. You can see the belly of sternocleidomastoid splenic. Then you will see the cyanosis. So cyanosis, again, I'm saying that it is a bluish discoloration of the mucous membrane. So you will be able to see the cyanosis. Clubbing, you can see in the fingers when you look, observe. And these patients, because they have difficulty in the expiratory phase, it's difficult for them to eliminate the air out. So they automatically at times start doing the pursed lip breathing. So you can observe under observation, these things you will observe. Now, when you will palpate, you can see the edema of the lower limb. If these patients are into progression stage and quad pulmonale is happening, so there are chances that the peripheral edema will be there and pitting edema can be seen. So pitting edema is when you will uh, compress your fingers, you can see the pit. And the classification of pitting edema according to the time duration and the depth I have taught you, so I'm not repeating it here again. Then because of the neck muscles overuse, you can see the hypertrophy of those muscles. When you will auscultate these patients, specifically when you will auscultate these patients, you can, in breath sounds, you can hear the expiratory wheeze, and during inspiration, you can have crackles as well. If the mucus hyperproduction has been there because of inflammatory changes, mucus hyperproduction, you can hear the crackles as well. So you need to work on that aspect. Now, if we talk of the then next part, which is very important, is as I said, that these patients have pulmonary manifestations as well as the extra pulmonary manifestations. So, peripheral muscles, assessment of the peripheral muscles and its strength becomes very important. As the patients, yesterday I explained you a vicious cycle of dyspnea, that when the patient gets the disease, the patient's level of physical activity reduces. The patient adopts more of a sedentary life cycle. When that sedentary life cycle is being adopted, the patient's symptoms further increase, breathlessness increase further, and that increased breathlessness further leads to adoption of more of the sedentary lifestyle. So because of that, the peripheral muscles, quadriceps is one of the muscles which gets affected very early, and the strength and loss in strength of those muscles can be seen. So it is important to measure the strength of the peripheral muscles in these patients as well, of the upper and the lower limb. Then the respiratory muscles, they start getting weak as well. So respiratory muscle strength measurement is also important. and we can see the neck vein distension so in during expiratory phase in these patients as well. These patients, as I told you, that they have the increased work of breathing. Now, work of breathing, repetitively, I keep on saying in my classes that work of breathing is normally done when the diaphragm is contracting, the muscle is working, it is an active phase. So there is some work of breathing done. We are breathing, the air is coming inside and it is facing some resistance. Okay, so from the elastic structures, from the airway resistance. So there is certain amount of work of breathing which is happening in all of us. But here the work of breathing is increased. Now that increase in work of breathing is because of the obstruction is there, so the resistance in the airways is further increased. So number first, why this work of breathing increases, that is to overcome the resistance of the obstructive airways. That is because of the mucus hypersecretion, that is because of the inflammation which is happening. Then secondly, expiration is a passive process. But now, here in these pathology of patients, because of the obstruction, they are not able to eliminate the air out. So, assistance is being given in the body, and it becomes more of an active process in these patients rather than becoming a passive process. So, as anything becomes active, there is certain amount of work done. In a normal state, that work is not being done. So, again, the work of breathing increases in these patients. Now, respiratory muscle, the inspiratory muscle action, which is now being it, they gasp for air. They will open their mouth and they will show the air hunger. So, sustained inspiratory muscle action throughout the respiratory cycle again increases the work of breathing. Then you can see the Hover's sign in these patients. These patients they compensate for the loss of bucket handle movement of the ribs. So, what happens is that if you can see that I have shown here in the figure certain things that the thoracic and the elastic recoil is directed inwards. The ribs become more of horizontal. In normally when I taught you, I told you that the ribs are more of obliquely. They are at inclined at an angle. They are not horizontal. But in these patients, the ribs they start becoming horizontal. Again, here in this, if you can see that this the diaphragm curvature is decreased, means that there is no proper relaxation of the diaphragm and it is in the mid of it. And also the muscles, they are not neither relaxed, so they are maintained in shortened state. So diaphragm will not work in complete, it's not in complete relaxation. And the third thing I said is that Hover's sign will become positive. Now, what is this Hover sign? Now, Hover sign is one of the signs which was named after Charles Franklin. And in this, what you will see is when we say that it is the a positive sign, what happens is that the lower rib cage that moves inward during inspiration instead of an outward. So normally what happens is during inspiration, the lower rib cage should move out. But here it is not happening. And this is happening because of a flat but functioning diaphragm. The diaphragm becomes flat because it is not going into complete relaxation. So this happens because the diaphragm is in partial state of contraction, or it is rather flat rather than being into complete exhalation. So because of that functioning of the diaphragm in that, this happens. So now, after looking after the sign itself, when we see the investigations, then what all investigations we need to get done in these patients? So, blood analysis will tell you if there is any inflammatory sign that will be indicated by the blood. If you are expecting cor pulmonale, then not in every case ECG should be done. If you are seeing the signs of any heart involvement and you see peripheral edema and all is there, a lot of cyanosis is there, then you can definitely go for an ECG. Next, radiograph should be done. Then sputum analysis to see whether there is any other infection or not. So color matters. Inflammation is indicated by color. Then amount of sputum again matters, and the consistency, whether it is a thin sputum or it is very thick sputum, then whether it is small amount or a copious amount, because that all will help you in getting your management part done as a physiotherapist. Then ABG analysis is important. ABG analysis, especially when the patient is hospitalized. In IPD cases, it becomes very important because that will help you decide that what kind of physiotherapy management, what kind of breathing strategies you need to adopt, because that will give you an idea that whether the patient is in respiratory, landing into respiratory, any kind of respiratory failures or not, or the PaO2 levels, PaCO2 levels, and the bicarbonate levels are normal or they are into hampered state. So that is important to decide what physiotherapy management. Medicine part will, they will look for their part. So I'm not talking much about the medicines, okay? I'm talking more with respect to the physiotherapy part, that these all important, these all investigations, they hold importance. Then PFT will help you know that whether it is a reversible condition. As I said, COPD is a reversible condition. In asthma, you after 2 hours, you can see that the airway narrowing is helped out and it reverses towards the normal. Whereas in COPD, you will not see these changes. So PFT will help you to reach to a diagnosis. Then alpha 1 antitrypsin deficiency screening is important in cases of emphysema. So this is how, what is the difference between a normal lung function and the obstructive conditions. So here on the left side, I've shown you the normal lung functions, and here on the right side, I've told you. So you can see that this residual volume, this is really, really increased. Now, functional residual capacity is affected because of the residual volume and because of the increase in residual volume. So you can see in especially in cases of pink puffers, the total lung capacity is increased. Now this is the COPD and a normal PFT. So here, if you look for the scooping is not much shown in this figure, but if you look for the values, because ultimately what we have to see, we have to see the ratio. It should not be less than 70%. So here you can see that the ratio is less than 70%. So this is indicative that there is some kind of obstructive changes. You need to look for the percentage value. So you just not looking at the graph, but also the value interpretation is equally important. So here we can see that the ratio is less than 70%. So classification of COPD by spirometry, if we say is, then we say mild when the ratio is less than 70%, but FEV1 is greater than 80% of predicted. So here, if you will calculate this FEV1 percentage, if we calculate this percentage, so how you will calculate this percentage of FEV1? You will divide this 2.35 by 4.15, and then you will multiply it by 100. So here this shows that this FEV1 is approximately 56%. It is it's seen that here it is 44.1 and this is 2.3. So approximately it is about nearly in the range of 50 to 60%, right? Roughly, if we see, and if we calculate, it's coming as 56.6%. So now if you see the severity, here you will say it mild when the FEV1 is greater than 80%. Moderate when FEV1 is between 50 to 80%, and severe when it is between 30 to 50%. Fine. So that is the severe category, FEV1. So here in this case, this is in the moderate stage because the FEV1 is between 50 to 80%. And very severe when FEV1 is less than 30% or FEV1 is less than 50% predicted along with the signs of chronic respiratory failure. So that will lead to the definition of very severe stage. Fine. So this is how you classify the PFT according to the COPD according to the spirometry. Then next, coming to the X-ray interpretations, lungs are basically enlarged Because of hyperventilation, you can see the diaphragm is not very dome shaped here. It is more of flattened, and we can count more number of ribs: one, two, three, four, five, six, seven. More than seven, and ribs can be counted because lungs are enlarged. The anterior-posterior diameter increases. You can see that the heart also looks tubular. Okay, so these are the main changes you can see. And here, see, in cases of emphysema, you can see the bullae. So, which are the black areas of lung round by they are surrounded by the hairline shadows. So, you can see here, you can see multiple bullae. Okay, you can see my arrow moving, so you can see the bullae in the lungs. So, when you need to perform the spirometry is performed whenever when patient comes with these signs and symptoms. So, the pulmonologist, they take decision for getting the spirometry done, that airflow obstruction. So, if EV1 is less than 80% predicted, or the ratio is less than 70%, this means that there is obstruction. But now, spirometry is not a necessary, it is not mandatory that this has to be done. There are other symptoms as well. You can identify it with the help of ABGs and the this x-rays and all, a lot of sequencing. So it is not the diagnostic procedure. It is advisable, but it is not mandatory for initial therapy. If again there are doubts about the diagnosis, then there may be that obstruction can be because it can be asthma as well. So, as I told you, that asthma is a reversible condition. So, there will be greater than 400 milliliters response to bronchodilators after two. I told you that how you need to measure the bronchodilator effect. So we need to give this amount, and again priorly पहले BFT करेंगे, then give this amount of bronchodilator, and then after 2 hours again you will. So when if you see that there is increase, then this means that it is asthma. So अगर drug therapy के बाद, even if PFT, this reversibility testing is not done, but if you see that you have done the testing, and if the after the drug therapy that is returning back to normal, okay, so COPD will not be present because COPD is not a reversible condition. If we talk of the medical management part, then medical management will include the smoking cessation. Then a lot of pharmacological management will be there. So maintenance management can be anticholinergics, long-acting beta-2 agonists, steroids. Fine. So the leukotriene receptor antagonists, these medications are mainly given for maintenance phases, and then for rescuing, short-acting beta-2 antagonists are given. Then antibiotics are preferred, and if the patient is having lack of oxygen, then supplemental oxygen is required. Surgical management, though, patients who have really progressive diseases, then in those cases, bulectomy, removal of these bullas, areas where having the bulla, then lung volume reduction surgeries can be done in patients who have a lot of increase in hyperventilation and a lot of hampered lung function. And if entire lung is being severely damaged, then lung transplantation can also be an option. Fine. So PT management, physiotherapy management, we will be doing in the next class. I hope now, is it clear with you people?
Yes, ma'am.
Yes, ma'am. Ma'am.
I hope that I was able to bring to you the difference in bronchitis and emphysema, what all symptoms the patient presents with, how the heart is being affected, how the symptoms develop, what it means, how the I have emphasized a lot on work of breathing, that because that is one of the domains where we should always work on. We should not just work on ventilation and perfusion aspects or just improving the pattern of breathing. Overall rehabilitation is important, and work of breathing is something which is often ignored. We don't take into consideration because it is multifactorial. So that has to be considered. Okay, so
Excuse me, ma'am. Ma'am, एक question है.
just a minute, beta.